Numbers are few, but our time is short, so we're going to get started. It's wonderful to have our senior residents ready to enthrall us with their wisdom and experience. It's nice that they all were able to bathe this week. We appreciate that very much. And they all look absolutely beautiful. Have we gotten pictures? We've gotten pictures? Okay. All right, so the order is up to them, actually. Looks like Bo is going first. So each of the residents will give a brief introduction of where they're going and what their plans are for the next year. And they will give their presentation. We're going to have them all speak and then sequentially ask questions at the end. 4 and then 3? Okay, so we'll do the first 4. You're on.
Good morning, everyone. My name is Bo Cates. My project is titled Increasing Resident Confidence of POCUS. That stands for Point of Care Ultrasound in Clinical Practice. Is this microphone a good height or a little?
Yeah, it's too quiet.
A little better? Okay. I have no disclosures. Next steps for me will be moving to the Reno area for a primary care sports medicine fellowship. Very excited for this. It was my top choice. It's got a heavy ultrasound exposure as well as integrating a lot of wilderness medicine, and I'm thrilled to combine those two passions of mine. After that, looking for a job. Can't wait. If anyone has any openings, let me know. And then my spouse, who works as a human factors engineer and has endured medical school and residency training alongside me, will continue her job working remotely for now. When I was doing literature review, this is kind of the common synopsis. The ultrasound is the future in medicine. But I would adjust this ever so slightly to say that it's in the present. This technology, it's not there to replace diagnostic ultrasound performed by a dedicated ultrasonographer, but to help you in making your clinical decisions faster. And there's plenty of data that shows how this does improve patient outcomes. It leads to a more rapid diagnosis, and of course, then shortens your time to care. And something that I have found personally, and several of my colleagues have, that it really helps patients get engaged in their care. Just as you would review an X-ray, CT scan, or MRI, they don't have to know everything that's going on in the screen, but pointing out abnormal compared to normal is very telling for them. I have a couple demonstrations of a few cases that kind of demonstrate how it did help me very quickly get a patient to care. The first is of a hockey player who suffered a contusion to his thigh. And I saw him about a week later, and he was complaining of fullness in the thigh. He's not able to bend it fully. He's not having neurologic or lack of pulses to indicate a compartment syndrome. Threw my ultrasound probe on, and along the diaphysis of the femur is a fluid collection concerning for either a hematoma or a seroma. Because I was able to diagnose this, I met up with Dr. Matson, got him in clinic, and I was able to drain off about 60 cc's of blood. And he immediately felt relief. And he was able to get back to play within just a few days. And hopefully this decreases risk of developing myositis ossificans. The second case here is of an elderly gentleman who I met for the very first time as a hospital follow-up. He unfortunately was diagnosed with metastatic prostate cancer and had significant pleural effusions while he was in the hospital with chest tubes. I saw him literally the next day, and he looked a little dyspneic. Breath sounds were distant. Threw my ultrasound probe on, and this rib angle, this is a rib shadow coming through, and the lines are kind of demonstrating that pleural space that we would expect lung tissue to be filled is in fact filled with fluid. And this rib is about the 6th rib in the intercostal, or the mid-axillary line. Of course, we're seeing a little bit of cardiac artifact, and then I don't know if that's tumor mass or just some tissue that's been pulled off. That's not the main goal. This fluid, though, confirmed that, yes, he rapidly reaccumulated. And instead of me sending him off for an X-ray or an ultrasound to then get the report later, I was able to get him in for a therapeutic thoracentesis the first thing the next morning. So prevented further delay in his care. And additionally, this is becoming a huge priority for medical schools. Something in the realm of almost 75% of medical schools are indicating that they are including ultrasound within the curriculum. So what better way to continue that by incorporating it into a residency training? And so, where we go? So my project focused on that and I created a quality improvement project to see how this would work. So my overall mission is just to promote the use of ultrasound with an aim statement of increasing resident use of POCUS and their clinical and their confidence in it within this time frame. And I did that by a few different measures. So first, gathered some general data, implemented some ultrasound lectures based off certain curriculum that we'll go into, tracked their utilization of ultrasound within their clinical practice, and then a follow-up survey to compare the results. So first is our general survey. We had 18 total respondents divided up into classes as such. And the initial question that I asked was, is this even interesting? So on a Likert scale of 1 being not interested, 5 being very, we had a very high score. So it was encouraging to see that I was on the right track or that it was a worthy pursuit. Background of where people were coming from showed that a lot of people did have some exposure, at least in many, about almost half of applicants, or at least half of applicants, were already using this within their practice. Now, anticipated use of ultrasound follows a different skew where people anticipate moving into their practice using this fairly regularly, at least one time a week for 2/3 of these respondents. So, dividing it up into systems kind of give me an idea of what people are used to ultrasounding, with obstetrics being the highest, and that follows kind of where people's overall confidence levels would fall within that. And asking what are people's barriers to care. This would be kind of taking the place of our traditional fishbone diagram. And people indicated that their personal skill in interpreting the results of the scan itself seems to be the most challenging area. And so that fit in well with why we decided to focus on a lecture and education session. And so coming up with the curriculum, I didn't have to do it from scratch. The American Academy of Family Physicians, as well as the American Medical Society for Sports Medicine, have ultrasound curriculum already built out, dedicated for clinicians such as ourselves, not radiologists, to learn these skills to apply for their patient care. And so I fine-tuned that down to things that seemed most applicable for our residents. You'll notice that obstetrics isn't on there because we get a lot of that already built into our system. So instead of hitting on something we're already good at, I wanted to focus on some newer concepts. And so these primarily consisted of a lecturer, Dr. Mattson, Dr. Bischoff, coming during one of our new lectures. I had written out our objectives for each of these systems, and we would make sure to cover those. We were scanning each other, with the exception being procedural, which is needle placement under ultrasound guidance. It's fairly poor form to poke your colleagues with needles repetitively. So a good alternative to that was pig's feet. And so if you do decide to pursue this further, that is an excellent model to use. My secondary question of how often is this being used and in what systems it consisted of a tallying sheet that I posted throughout the hospitals where residents tend to hide, and collected this data monthly, and we'll go through those results together at the end. After these learning sessions and at the end of the year of my collection time frame, this was our final results on confidence, and overall showed a nominal increase in every category for that, with the most prominent being within the pulmonary system. From a qualitative standpoint, there was a lot of positive response to this study, of incorporating ultrasound, and a lot of comment on, can we do this more? Can we adjust curriculum to grow more and more confident in this? And additionally, our tally results by class showed that we had over 767 ultrasounds throughout this time frame, and I'm fairly confident that we didn't collect all of that data, especially within the first year class. I know for a fact that they did a lot more than that, but I'm not going to hold them accountable, because having a third year say do more administrative burden is never fun, and I remember doing that. Dividing it up by system, Busy slide, but focus in more on lower extremity. That seemed to be our most common area to ultrasound, followed by obstetrics and then the upper extremity. I do want to note that our procedural ultrasound tracking was very impressive, 13%. And I think that speaks to the skill level of the residents within this program and a unique thing they can offer to their patients as they move into their practice. So overall takeaway, yes, this project did show an increase in resident confidence by doing roughly monthly ultrasound training, focusing on data points, systems that are unique that the family practice physician would face. It is something that gives residents confidence with using their procedural skills, and I think future direction would incorporate increasing resident competency, not just confidence within this skill set. And that's something that's already underway under the guidance of Dr. Clark Madsen. It also follows very well with the new ACGME curriculum changes of looking at competency-based training. So special thanks to my residents for listening to me bug them all the time about this, Dr. Madsen for helping coordinate this project, and Kay Holmes for coordinating all of our lectures, our lectures, of course, and my wife, Dr. Erica Barhorse Cates, with helping with some data analysis. My references, and thank you for your time.
That was awesome. Nice work, Bo. So I'm Austin Dinkle. I'm one of the third-year residents as well. This is the end of my 2-year project. This is the financial impact of improving diabetic HCC verification at Porter Clinic. I've got nothing to disclose. Next steps, I joined a small group of family docs that cover rural critical access hospitals. I'll be doing mostly inpatient medicine. I'll be moving to Denver, Colorado. I will be doing a little bit of outpatient, mostly inpatient. The first hospital I'll be at is in Rawlins, Wyoming, and I'll get to do some teaching as well, which I'm excited about. So for a little bit of background here, for higher HCCs, or hierarchical condition categories, these are ICD-10 codes used by CMS, and it helps show patient complexity within value-based healthcare. So these include codes from anything from like diabetes with hypertension, atrial fibrillation, COPD, heart failure, sepsis, a wide variety of different codes. These are put together for each patient in order to put together an RAF score, which is a risk adjustment factor score. These RAF scores, they directly correlate with reimbursements to the clinic to help care for our patients there. And the codes need to be verified once a year. It is important to code appropriately so the clinic can care for the patient with those funds. This also helps match the outcome with expected. So for example, if we have a very sick patient, everyone knows it's a very sick patient, but they don't have all the codes that are documented in the chart. If that patient has a bad outcome, it's going to look like that is something that's not necessarily expected, even though everyone knew they were a sick patient. So that can help, or that can hurt practices in certain models. They can miss out on the opportunity for shared savings for that patient. And here is an example for RAF scores. On the top left here, we have hyperlipidemia and diabetes. Hyperlipidemia does not risk adjust by itself, so then we just get the diabetes code for that total IRF for that patient. On the right there, we do have the hyperlipidemia, or the diabetes with hyperlipidemia, and that shows a higher complexity of a patient and a higher RAF score for those. Same thing down below, only difference is chronic kidney disease does actually risk adjust, so that'll add on to the diabetes there with a little bit higher RAF score. And then same thing, combining them together results in a higher complexity for the patient. So why is this important? For our clinic, our improvement in HCC verification, this resulted in almost $1 million in increase in reimbursements. Now, this is just an estimate because actual payments from insurances do vary, but yeah, it resulted in an estimated almost $1 million. So phase one of my project, this was my second year QI project, and I looked at different ways that residents used these codes throughout clinic, how they documented it, what factors play into this. We went through all of this with my team, creating a root cause analysis. We wanted to try to address something that would be impactful and long-lasting for this, and we came up with trying to address the workflow. So we came up with this sheet here. The resident would meet with the MA prior to the patients for the day. They'd go through all the diabetic patients, and then they would go through all the labs that patient was due for. And I listed the common diabetic HCCs and the need to link the complicating factors here on the sheet to make it really clear to the resident, these are the codes that we should be using for these patients. And results from phase one for diabetes patients that had HCCs verified more in 2022 than 2021 was 167 new patients with these diabetes codes. My intervention was specifically in October, so we did have a little bit of an increase after that point. Okay, so moving on to phase two. This is my third year project. This is the financial impact of improving the diabetic HCC verifications. For phase two, I wanted to look at something a little bit different. For this one, we decided to address education, for HCC education for residents. The thought being that in the residency, 7 third years graduate every year. Then we have 7 new interns, and everybody knows intern year is crazy, and you've got a billion things going on, and you're just trying to figure out how to not kill somebody with Tylenol. So HCCs are at the bottom of that list, as they should be. So I wanted to give them a little bit of time to kind of get their feet underneath them and then introduce this concept. And I had Castell help me with that. They are a value-based healthcare company inside Intermountain. And they actually do monthly teachings for us, but specifically for this one, they did an HCC teaching over the general aspects of HCCs and then specifically into the diabetes HCCs here. This was done on August 21st, 2023. September 22nd, our panel sizes did decrease overall. This was from previous residents that were getting jobs, so these patients were assigned to non-Castell groups. So our numbers decreased, not unexpected, but they did decrease overall here. Intervention number 3, on October 5th, I sent out individual HCC verification rates to the residents for patients on their panel. I just wanted to make it really clear to the residents, these are the patients that we're still looking to try to capture these HCCs for. Intervention number 4, this wasn't my intervention, it was more just having shared goals with the clinic. The clinic manager did send out weekly emails, and she's still doing that as well. I got one this morning, actually, but they're sending out weekly emails for patients needing HCC verification prior to the visit. And this is not exclusively diabetes HCCs, but it does include this as well. So we hit the education in a variety of different ways here. And moving on to the results. So the 3-year total diabetic HCC verifications, as you can see, the gray is 2021, 2022 is the orange, and then the blue is 2023. We overall had an increase throughout all 3 years. So the total number of diabetic patients with HCCs that have been verified has increased overall. The new diabetic patient HCCs has increased as well. As you can see, there's quite a large increase throughout 2023. Now, this could be anywhere from patients in our clinic who are already diabetic that just had the appropriate codes in their chart, or this could be new diabetic patients that are coming into our clinic. So a variety of different things. We had quite an increase on this one, which is awesome. So the 3-year diabetes HCC verification percentages, this was actually a little bit lower for 2023 comparatively to the other years. You can see 2022 is 80%, and then 2021, 87%. Basically, this shows that we still have some work to do with this project. I do think it's probably because we have a higher number of total patients that have these HCCs, so we didn't quite get all of them captured, but still work to do is the important part. Moving on to this slide, so for 2022 to 2023, the average RAF scores, which for a reminder is the risk adjustment factor, and this is what correlates with reimbursements to the clinic. For 2022, it was 1.178, and then 2023, it was 1.672. So we had quite an increase. This is for our diabetes patients in our clinic. And then this correlated with an average capitated payment per member from CMS of almost a $4,000 increase per person. So it was about $9,400 in 2022 to about $13,000, almost $400 in 2023. So in summary, for our clinic, we did have improved HCC verification rates, the most of any clinic in the system, actually, which is awesome. We were able to increase payments to help care for our patients. And the almost $1 million, the estimation for this comes from the amount of new diabetes patients that we had, whether that's the new patients or whether that's previous diabetic patients that just have the new diabetes codes for them. But we had quite an increase there. This is probably more of a statement of where we started at rather than now we're kind of catching up, but still I think it made quite an increase here. For the residents, we were able to get a new ultrasound probe, which is awesome, and then a new OMM table with some of these extra funds. Next steps for this project, I believe the education of these HCCs is something that's going to need to continue as it goes on. And this is something I believe Castell will continue to do with us monthly while value-based healthcare is the thing. For me, I am thankful for all the education and quality improvement here at McKay-Dee. It's something that's going to follow me along wherever I go. And I just want to thank my team, Castell, Jennifer Swenson, and Kelly Callister. These are clinical coding specialists there at Castell. They were very helpful throughout all of this. Dr. Madsen, Dr. Stoddard, Dr. Campbell, and then all of the residents. And that is it. Thank you.
Thanks, Austin. That was excellent. My name's Mary. So I did a project a little bit different than Bo and Austin. I just did a deep dive into the existing research on a topic. We're going to be talking about long-acting injectable buprenorphine formulations for the treatment of opioid use disorder. Talking about where I'm heading next year, or this summer rather, I'll be heading home to rural Vermont and practicing at a small federally qualified health center in Wells River. I'll be providing primarily outpatient care, but also providing obstetrics and newborn care in the hospital. No disclosures. So why are we interested in this topic? Well, I think as most of us know, opioid use disorder poses a gigantic burden on the health of people in the US and worldwide. It's associated with huge increases in poor health outcomes, increases in all-cause mortality, mental health diagnoses, suicide, but also poor outcomes with regard to psychosocial factors such as housing stability, employment stability, criminal justice involvement. And this is not a problem that's slowing down anytime soon. So opioids are the main drug implicated in fatal overdoses worldwide. In the US, deaths from opioid overdose have overtaken motor vehicle accidents as well as gun deaths as the leading cause of preventable accidental deaths. And while fatal overdoses from heroin and prescription opioids seem to be leveling out in recent years, deaths due to synthetic opioids like fentanyl and its analogs only have been increasing. We do have a primary data-driven treatment for opioid use disorder, and that, of course, is medication-assisted treatment. Studies have estimated that there may be up to a 50% decrease in all-cause mortality when you successfully induce somebody on medication-assisted treatment. So this is huge. It's effective. We know it works. The existing FDA-approved treatments for opioid use disorder include methadone and buprenorphine with or without naloxone. And of course, methadone and buprenorphine are our opioid agonist treatments we have. FDA has also approved naltrexone, the IM form Vivitrol, for treatment of this disorder. But due to their increased efficacy and ease of use, methadone and buprenorphine formulations remain our gold standard first-line treatments of care. Naltrexone is second line. And between methadone and buprenorphine formulations, while they are both wonderful medications, increasingly, due to the ease of access and efficacy of buprenorphine formulations, they are becoming the preferred treatments for many patients in the States. But they're not without their limitations, right? So with buprenorphine formulations, you have the potential for suboptimal medication adherence, diversion, IV misuse, and unintended exposures to other populations, for example, kids in the household. So with these limitations in mind surrounding buprenorphine oral formations, in the last 7 years, 2 companies have gotten injectable long-acting formulations improved. What I'd like to do for the remainder of the talk is talk about these 2 formulations and kind of the existing evidence we have for their safety and efficacy. So the 2 injectable forms, Sublocade, approved in 2017, and Brixadi, approved more recently in 2023. So first, let's talk about Sublocade. What we'll do is talk a bit about the medications and then the phase 3 trials that led to their approval. Sublocade is an injectable long-acting buprenorphine, comes in monthly subcutaneous injections, and there's 2 different dosing strengths, 300 and 100 milligram dosing. Typical use means that patients are induced on the 300 milligram doses and then transition to the 100 milligram dosing. The excipient that this medication is delivered in forms a solid depot in the subcutaneous tissue of the abdomen after it's administered and then proceeds to dissolve over the course of a month. This is the structure of the phase 3 trial that led to Sublocade's approval. So it was a multi-center, randomized, double-blind, and placebo-controlled phase 3 trial. Participants were recruited that had moderate to severe opioid use disorder, and they were excluded if they had had MAT treatment of another form within the past 3 months, if they were on chronic opioids for another reason, such as treatment for chronic pain, and if they had severe alcohol use disorder or any amphetamine use disorder, but most other substance use disorders were allowed as comorbid disorders in this study. All subjects underwent a 2-week run-in period with sublingual buprenorphine naloxone, and then were randomized into one of 3 arms. In the placebo arm, they received monthly injections, and then in the 2 study drug arms, they either received monthly 300 milligram injections of Sublocade or started with 300 milligram injections for 2 months and then were transitioned to 100 milligram injections. All of them received individual drug counseling throughout. So this was the structure of the study. Let's take a look at the endpoints they examined and the results they found. So all along, they were collecting data on urine samples with evidence with or without illicit opioids. They were talking to patients about whether they reported use of illicit opioids. They were talking to them about withdrawal and craving scores. And the main primary endpoint they looked at was the percentage of abstinent urine samples. So urine samples without evidence of illicit opioids between participants, and that correlated with negative self-reports of use as well. So for this main primary endpoint, both treatment arms of Sublocade were clearly superior to placebo. This is a graph showing the percentages of negative urine samples for participants throughout the course of the study. In purple and red, we have the 2 different dosing arms of Sublocade, and in blue, placebo. The numbers on the slide simply show the average degree of abstinent urine samples for each group. In terms of secondary endpoints, they looked at treatment success, which they defined as participants having 80% or more negative urine samples throughout the entire course of the study. And in that regard, they did find that both treatment arms of Sublocade were clearly superior to placebo. They looked at withdrawal and craving scores using our opioid withdrawal scoring and visual analog scales of cravings, and found that while these scores were relatively low across all arms, they tended to be lower in the Sublocade treatment arms. Last, they looked at study retention and found that there was nearly twice the rate of study retention in the Sublocade treatment arms as compared to placebo. In terms of safety, overall, Sublocade was found to have a similar safety profile as what we know about sublingual buprenorphine naloxone. The most common adverse events throughout the study: headache, constipation, nausea, some of the things you think about with like opioid toxidrome, also injection site pruritus, but this occurred in both treatment and placebo arms. Strengths of the study: it was placebo-controlled, it was randomized, and the investigators felt that by allowing lots of realistic comorbidities into the study population, that they created generalizability with this. They studied a group of people that were realistic to those we treat every day for substance use disorders. Weaknesses: didn't compare the two dosing arms of Sublocade to each other. If people couldn't make it through that initial run-in period with sublingual medication, they were excluded from the trial. And I think most importantly, they weren't comparing Sublocade to the existing standard of care, right? They were just comparing it to placebo, not to methadone, not to an oral buprenorphine formulation. So they weren't proving non-inferiority. Next, we'll talk about Brixadi. So again, recently approved in 2023. The dosing of this long-acting injectable is a little bit different than Sublocade. You can go for monthly or weekly injections, and within each of those time frames, there's flexible dosing. So there's 4 different strengths of dosing you can offer to patients. It also has a different excipient, so when injected, this forms more of a gel in the subcutaneous tissue as opposed to a solid depot. This is the structure of the phase 3 trial that led to Brixadi's approval. So this was a multi-site, randomized, double-blind, double-dummy, placebo and active-controlled study. Again, participants were recruited who had moderate to severe opioid use disorder. This study had slightly more stringent exclusion criteria. So in addition to not recently being on MAT and not needing chronic opioids for another condition, people were excluded who were on other strong CYP-inhibiting medications, who had strong suicidal ideation, existing QTC prolongation or considered high risk for, or existing LFT elevations prior to the study. They were also excluded if they had pending legal action. To start, every subject received 1 test dose of 4 milligrams buprenorphine naloxone, and then they were immediately randomized into 2 arms. In the placebo arm, for the first 12 weeks, they received weekly placebo injections, as well as daily sublingual buprenorphine naloxone. And then in the second phase, they received monthly placebo injections and stayed on daily sublingual medication. For the treatment arm, they started with weekly Brixadi injections, and then in the second phase, graduated to monthly, all along staying on a daily sublingual placebo. So as far as the endpoints they examined, they looked at what they defined as their response rate, which they talked to the FDA, and the study company came up with this definition of people having negative urine samples for 8 to 10 visits during the trial period in weeks 9 to 24. So they felt this to be a significant number of visits where people were having urine samples with negative illicit use. They also looked at the overall proportion of opioid-negative urine samples for the entirety of the trial. For both of the primary endpoints, they found non-inferiority of Brixadi, so of the study drug. Then they looked at some secondary endpoints. So one, they looked at study retention rates, and they didn't find a significant difference between the two. Then they looked at the total percent of negative opioid samples between weeks 4 and 24 of the study. And looking at this chunk of time, they did find that Brixadi appeared superior to sublingual buprenorphine naloxone. And that's what this chart is showing. So you can look at the percentages of negative urine samples throughout the study, and if you kind of look to that 4-week juncture in the study, then you can see this separation of the 2 study groups, where those with on the study drug showed significantly higher abstinence to illicit opioids than Suboxone. Strength of the study was double-blind, double-dummy. They had it was also active controlled. They had a large and geographically diverse sample size. And they too felt like they enrolled participants who are very characteristic of those we treat with opioid use disorder in clinic every day. Another big advantage was there were flexible treatment regimens here. So if subjects weren't responding to their sublingual or injection doses, investigators could adjust their doses. So it was a little bit more realistic to what real-world treatment looks like. Weaknesses, they didn't pay attention to the adherence to the sublingual medication arm, and then only one site was primary care based. Thinking about conclusions from both of these phase 3 trials, so Brixadi and Sublocade, I think we can safely say they both showed efficacy for long-acting injectable buprenorphine for the treatment of opioid use disorder, but the two trials went about things differently in an important way. So while Brixadi was able to show non-inferiority to the existing standard of care, sublingual buprenorphine naloxone, and potential superiority in one regard in terms of abstinence, Sublocade was just compared to placebo alone. They didn't prove non-inferiority. The safety profiles of each medication were comparable to that of sublingual buprenorphine. And the endpoints of all these studies were really focusing on abstinence from other opioid use over time. I think we definitely need more research in this area. These are relatively new medications, and I think there's a lot we have to learn about their potential use. Looking forward, there is an important study that is enrolling currently, the VA BRAVE study. So this is a Veterans Health Administration trial that's enrolling across the US, including in Salt Lake. And what they're doing is comparing sublingual buprenorphine naloxone to Sublocade. So we're getting that head-to-head comparison. They're looking at it over a longer period of time, 52 weeks. And what I like about this study, while they are focusing still on abstinence from illicit opioids, they're including other important primary endpoints and secondary outcomes. So they're looking more closely at retention in treatment over a long period of time. And then they're looking at secondary outcomes that are really important to the health of our patients. So they're looking at measures of other drug use, psychiatric symptoms, medical outcomes, including HIV, Hep C, and Hep B transmission rates, as well as social outcomes, housing and employment stability, criminal justice involvement, cost effectiveness, and service utilization. Another future step I'd like to point towards, so there are emerging case reports showing that we can effectively use these injectables to taper people off of MAT treatment. If you talk to folks in Ogden who are already using Sublocade and Brixadi, they already know this because they're doing this in practice, but the data in terms of research hasn't really caught up to this. So, when we think about recommendations for substance use treatment, because we know there's decreasing mortality for every year that you remain on treatment with MAT, the official recommendations are that people stay on medications indefinitely. But we know that that's not going to work for all of our patients, and certainly staying on a medication indefinitely, certainly after somebody stabilizes for a long period of time, that's not going to be a good fit for everyone. But methadone and oral forms of buprenorphine can be notoriously hard to taper off of because of withdrawal effects. And we're seeing emerging case reports that people have successfully administered 100 milligram doses of Sublocade and tapered people off of oral treatments. Anecdotally, too, we also know those who are treating with this in this community know that if somebody's stabilized on an injectable treatment, it is easy to taper off of that with any medication supplementation. So overall, there's strong evidence for the efficacy and safety of both of these long-acting injectables, and there's the potential for the advantage, at least with regard to Brixadi, over sublingual options in terms of illicit opioid abstinence. But we need more studies. We need more studies that are looking at retention, efficacy, abstinence over time, and looking at these important secondary health and psychosocial outcomes. There's also strong potential for the use of these to help us taper patients from MAT treatment if they feel they're ready. And overall, I think these are just a valuable addition to our toolkit with treating opioid use disorder. Every patient's needs are going to be different, so it's on us to make sure that we understand the potential benefits of all treatments we have at our disposal, and so that we're able to taper care to the individual. These are my sources.
Morning. My name's Andrew. I'm one of the current third years, and I'll be talking today about diabetes and continuous glucose monitoring. More specifically, addressing the question, what role can CGMs play in lowering a patient's hemoglobin A1C? I have no financial disclosures. And just before we dive in a little bit about my plans, I'll be joining Tanner Clinic out at the Syracuse location, and I'm excited to get started in July and feel really fortunate to be joining a great team there. And yeah, just looking forward to that. So on to diabetes. As many of you are likely aware, diabetes is expensive. And in fact, it's the most expensive chronic condition in our nation. 1 out of every $4 in U.S. healthcare is spent on patients with diabetes, and $237 billion is spent each year on direct medical costs. And money isn't everything, but these figures kind of illustrate the problem or the significant issue in our patient population. And thankfully, diabetic patients have many tools at their disposal, including exercise, nutrition, medications, and yes, CGMs. So CGMs continually monitor your blood glucose, giving you real-time updates through a device that's attached to your body. And according to the American Diabetes Association, some benefits could include potentially saving money, avoiding complications, and reducing risk of hypo or hyperglycemic events. Last year, for my qualitative improvement project, I wanted to focus on improving diabetic care in our residency clinic. And during discussions with our clinic care manager and pharmacist, we discovered that the process for checking in CGMs was cumbersome and possibly leading to some patients discontinuing their CGMs. So we decided to make some changes. And we saw with our changes of the check-in process that there was an increase in the CGM use in Porter Clinic. So taking that, I guess, a step to this year, I decided to actually take a step back and return to the literature to determine, by increasing the number of CGMs, are we actually improving our patients' diabetic care? Does this improve our patients' hemoglobin A1C? And so we'll kind of dive into some of that research right now. CGMs are fairly new technology, and with the first professional CGM getting approved in 1999, some of the studies we'll go over today are quite early on in that history, and so we'll walk through the following 4 studies in chronological order, starting with this one from way back in 2006. It's titled Continuous Glucose Monitoring Guided Insulin Adjustment in Children and Adolescents on Near Physiological Insulin Regimens. In this study, they took 36 kids with diabetes and A1Cs less than 10% and placed them into one of 2 groups, CGMs versus finger sticks, and that's kind of the trend through all these studies. Then they rechecked their A1Cs after 12 weeks, and please note that the CGMs were only used for 72 hours every 3 weeks. Both the finger stick or the control group in this study and a CGM or the intervention group experienced an improvement in their A1C of about 0.4. They found no statistical difference between the 2 groups. The group determined that there was no additional benefit from CGM-guided insulin, adjusted every 3 weeks for 3 months. Many subjects did comment that they found it useful to see a graphical presentation of the effect of different activities, but this was not translated into improved management. Some of the limitations of this study could include the fact that the CGMs did not provide live readings to the patients. CGMs were only used for 72 hours every 3 weeks. The study only lasted 3 months, and that patients with A1Cs greater than 10% were excluded. Our next study is from 2013 and is titled A Comparison of Internet Monitoring with Continuous Glucose Monitoring in Insulin Requiring Type 2 Diabetes Mellitus. They took 50 patients with A1Cs greater than 7% and placed half in the CGM arm and half in the self-monitoring arm, with the plan to compare the 2 groups at the end of 6 months. So the patients were randomly assigned to one of the two groups. The control group received a blood glucose meter, test strips for testing 3 times a day. The patients in the CGM group were trained by a registered nurse on the product is called the Guardian Real-Time CGM System, which is a Medtronic product. Both groups then sent in their reports to their endocrinologist every 2 weeks via the internet, and the endocrinologist would make adjustments based on that data. The researchers assumed that the patients adhered to their insulin and medication dosages as recommended, and as you can see, both groups' A1C values were improved after 6 months. The CGM group decreased their A1Cs by about 1.25, and the control group decreased theirs by about 0.8. While the CGM group in the study had greater improvement than the fingertip group, it was not found to be statistically significant. And the authors commented that while the CGM use was effective, it proved to be invasive, costly, and subjected patients to subcutaneous infection. And they felt that the fingerstick blood glucose monitoring to be more favorable because it didn't have some of those same risks. Our third study is titled Effective Continuous Glucose Monitoring on Glycemic Control in Adults with Type 1 Diabetes Using Insulin Injections. And this was another randomized controlled trial where CGMs were again pitted against the standard of monitoring with finger sticks. Patients were randomly assigned to one of two groups. The control group was asked to perform home blood glucose monitoring at least 4 times daily, and the patients in the CGM group were provided with the Dexcom G4. Both groups had follow-up visits at 4, 12, and 24 weeks. So the findings in this study, the primary outcome studied was the median reduction in hemoglobin A1C from baseline, or the mean reduction, sorry. In the CGM group, there was a reduction of 1.0 at 24 weeks compared to a decrease in 0.4 in the control group. As secondary outcomes, metrics for time in range, hyperglycemia, hypoglycemia, and glycemic variability favored the CGM group compared with a control group. Limitations in this study, it was performed in 2017, which is more recent than the other studies, but or was published in 2017, but actually performed in 2014, and thus the Dexcom G4 was used, which still required 2 calibrations each day. Today, devices require less calibrating, if any at all. Also, the authors felt that in light of the eligibility criteria, the results could not be applied to patients younger than 26 years old or with A1Cs outside the range studied. They also felt that the consent process had the potential to exclude individuals who might be less adherent with CGM use than the cohort that was studied. The fourth and final study is titled Initiation of Continuous Glucose Monitoring is Linked to Improved Glycemic Control and Fewer Clinical Events in Type 1 and Type 2 Diabetes in the Veterans Health Administration. At the time of publication, this was the largest study to date, and they looked retrospectively at patients with type 1 and type 2 diabetes and the impact initiation of CGM use had on A1C, hypo and hyperglycemic events, and all-cause hospitalization. Looking first at some of the results for the patients with type 1 diabetes, their baseline A1Cs were noted, and then the data was extracted from 6 months and 12-month intervals. As you can see, A1Cs were improved in the CGM group while essentially remaining unchanged in the control group. They went from 8.54 at baseline down to 8.22 in the CGM group. And then similar results can be seen with patients with type 2 diabetes. A1Cs went from a baseline of 8.70 down to 8.21 at 12 months. So the findings in this study show that in patients with type 1 diabetes, CGM initiation was associated with reduced risk of hypoglycemia and then reduced risk of hyperglycemia for type 2 patients. Both groups experienced a decrease in all-cause hospitalization when CGMs were used. Some limitations, as previously mentioned, this was a retrospective study, which comes with the typical limitations there. Some other limitations could include the fact that because diabetes is an exclusion criteria for enrollment in the military, the type 1 patients in this study reflect only those with adult onset disease. Also, the number of females was low in the cohort, and type 2 diabetic patients not receiving insulin were excluded. And all these limit the ability for this study to be applied to a more general population. In summary, the most recent research has shown an association with CGMs and improved A1Cs, but CGMs on their own cannot lower a patient's A1C. They don't physically stop us from eating donuts. I know I wore a CGM for 10 days and I still ate things I probably shouldn't have, but I did think twice about it. They do not on their own change medication regimens. Ultimately, CGMs are a tool that must be utilized in order to make a difference. And none of the studies in this presentation included closed loop systems with insulin pumps, but that's where the research and technology is headed, and it'll be interesting to see kind of where things go. For now, I think we can be confident that by encouraging our patients to use continuous glucose monitoring, we'll be helping them improve their overall care of one of the most common and costly conditions in America. And here are my references, and thank you.
Okay, we'll take questions if there are any for our first 4 presenters. Kurt's first. You raised your hand too slow, sorry. That's the way it goes.
Excellent presentations, and just first off, I would be proud to work with any of you. You have a great class, and it's great to see you guys. Mary, I have one question for you and then one for Andrew. Mary, pregnancy and long-acting.
Great question. So the data is not great for the use of the injectables in pregnancy. Pregnancy was another exclusion factor from both of those trials. When we look at animal data, so when we dose in animal trials, when they have rats on significantly higher concentrations of the injectables, they showed theoretical harm to the development of fetuses early in pregnancy. That being said, I think the expert recommendations on injectables are kind of similar to some of the more high risk or gray area of mood medications we use, where there's theoretical risk of harm for the fetus with some of these medications, but you have to balance the stability of mom on medication and her well-being with risk of fetus. So I don't think it's an absolute contraindication, but the data is not there yet. Another interesting thing to think about is when we think of how to limit harm to the fetus and maintain a safe pregnancy in those with opioid use disorder, it's not so much about having them on a lower dose of their opioid agonist. It's not so much about, avoiding high doses of methadone or buprenorphine. It's more about ensuring that physiologically they're not undergoing daily fluctuations in withdrawal symptoms, and they're not going through severe period of withdrawals. So when you think about the injectables, once you stabilize them on them, you're maintaining a really level plasma concentration of the drug as compared to daily medications where you're fluctuating up and down, and you can, take a break or lose the medication, go through withdrawal. So that's another safety factor to think about. I think in the future, we might be using these in pregnancy more often.
No, that's exactly where I was going and hoping we have that opportunity. Let's see, Andrew, the question that I had is I looked at those studies, and I appreciate the review of the studies. I mean, we're using CGMs all the time now, and it sounds like there's not a whole lot of evidence for them. But I think there might be. I don't see a study designed to say, let's take the poorly controlled diabetic and see where it is, because that's where I see the benefit in my practice, experience-wise. Have you seen any, or are there any studies designed for that to happen?
A lot of the studies that I saw, they excluded a lot of the patients that were really poorly controlled, which I think is unfortunate because they probably have the biggest, benefit that they can make with making simple changes with dietary stuff, which in my personal practice, I feel like I have seen with patients that I've started a CGM on, it allows them to kind of take control of their life and make the dietary changes they need to, but I didn't see anything in the
Nothing.
recent literature that I was looked at, the studies that I looked at,
Yeah.
unfortunately.
Maybe we get one of the second years to jump on that, huh, and
Yeah.
take that study.
Andrew, so comment question. One of the biggest challenges I have with CGMs is accessing the data. I have a lot of patients who come in and they don't know how to work it, or they don't have it on their phone, or I can't get a printout of the data to make decisions. We have a clinical pharmacist, but she's not always available at every patient appointment I have. I'm not sure how to get around that, but one thought in my mind is, you know, if you could build that into an EMR, you know, like Epic coming next year, then, you know, if that data was a click away, then think how much easier it would be to access that information. Because ultimately, in a lot of these patients' visits I have, I'm not making real-time decisions because I don't have their data available to me. And how can we change that? Because if we can't have the data, it's what good is it?
Yeah, I agree, and that's kind of what we tried to address in Porter Clinic last year, because that's the same thing we were finding as providers didn't have that information in front of them, even if their patient did have a CGM. What we kind of did in our clinic was train the front staff with a little bit more training on how to check those CGMs in. And the problem with that, I guess in Porter and probably all clinics, is we have turnover of staff, and then now our front desk doesn't necessarily know how to check those in, and MAs aren't printing out the results. And I find myself with my CGM patients looking at it on their phone oftentimes rather than having the printout handed to me, but I agree. I think the second study that I talked about, where they did the internet monitoring and they emailed their results into their endocrinologist every 2 weeks, both of the groups had improvement, but I think that was because the data is getting to the provider, and that's, I think, the benefit that a CGM can help with is, you know, the patient doesn't have to do the finger sticks 3 or 4 times a day, but we can still get that data, which is getting past the hurdle of actually getting it printed out.
All right, I got 2 questions for Mary. You knew this was coming. One thing that I was kind of disappointed that the studies didn't show any comparison of buprenorphine to naltrexone, because I feel like that's kind of a good comparison. It's readily available and everything. And you kind of mentioned a little bit there, like it's a next step kind of off tapering or anything like that. Is there any studies that kind of show that, or any studies that show that maybe it's a good taper to naltrexone as well? I mean, because I feel like that's kind of like the next step after buprenorphine.
So, no studies showing that it's a taper to after naltrexone. And then the existing studies that I found were really just the case reports. I mean, the other thing you can look at too is just the existing pharmacodynamics data from the medication approvals themselves. So if you look at the drug labels and kind of read about the pharmacokinetics on, about each injection, they're very clear that for discontinuation from those medications, you don't need to do anything special. You don't need to actively taper. You should offer, supplemental sublingual medication if you need to, but there's no official need to taper, like with lower doses from those medications. But that's the only other decent chunk of data. And then as far as comparing the injectables head-to-head with naltrexone, I mean, first, I think what we need more of is head-to-head studies with naltrexone and then the sublingual buprenorphine and methadone. So we have some of those studies, but they can show, if you successfully induce somebody on naltrexone treatment, if you get them through those 10 days of abstinence required and keep them on the study drug, that they have similar rates of abstinence as those on, Suboxone, but they haven't shown similar rates of retention in treatment over a long period yet for that. So Yeah, we need more data on it. I think naltrexone's a good option for some people, right? People who just don't want to be on mu agonists, people who are on lots of other CYP inhibiting medications, because naltrexone's not, isn't processed by the CYP system. But it has it's hard to get on it because you need that initial 10-day of absence period. And then one risk to think about with it is as you near the end of the Vivitrol dosing period and the mu blockade lessens, you're at more risk of serious and fatal overdosing from opioids if you go back to use at that time because you've lost your tolerance. So we just need more data.
And I think, I guess, one challenge too with the going from the injectable buprenorphine to the naltrexone would be making sure that it's completely out of the system as well, which would be hard to do, which is another challenge going to from those two.
Yeah, I guess thinking about that, so if you look at plasma concentrations for the injectables, they found that study drug might be left in people's systems up to 12 months later, which is why it's such a great thing. It's so easy to taper from, but yeah, absolutely, that would pose a problem for naltrexone.
Definitely. And then I had another question for you too. It looked like, at least in the second study, they had the induction dose of the buprenorphine of at least like 4 milligrams or such. That's a pretty low dose of buprenorphine, and those of us using it, that most patients are like on 16 and even sometimes higher of those doses. What's kind of the dose equivalent of the IM buprenorphine to kind of the sublingual buprenorphine? And is there like a role for like higher or kind of titrating that a little bit more?
So off the top of my head, I know that a little bit better for Sublocade. I know, at least in practice around here, talking to folks like Jeff David, when we're transitioning people who have stabilized on Suboxone to Sublocade, if they've been stable on higher doses, so between 18 and 32 milligrams a day, often, more often those patients may end up staying on the 300 milligram monthly doses of Sublocade rather than inducing the 300 milligrams for a month or two and then switching to 100 milligrams. With Brixadi, I forget off the top of my head, there was a chart that I took out of my presentation, but basically if you look at the information that comes in the drug insert, they do have recommended transition doses depending on what you've stabilized on for Suboxone. And the other thing about the study, so they had that tiny test dose of the 4 milligrams, basically just to see can you tolerate one dose. But then the nice thing was in both, the Suboxone arm and the Brixadi arm, they could adjust and make sure that people were titrating up to a good dose to minimize cravings. People did not, once they kind of stabilized on a dose in either arms, there was really minimal use of any supplemental medication dosing, so it showed the investigators did a good job of getting people ramped up to the dose they needed to be on.
Go ahead.
No,
Nope,
defer to the
you're
MC.
taller. You're
I'm
first.
taller. I want to reiterate and double down on what Dr. Ruffman said. I was impressed by all of your presentations, by the topics. They're quite timely. I'm thrilled to hear and see that MAT is part of the training now at the residency. I'm really thrilled to hear that access to butterflies and POCUS training is part of the training as well, and CGMs. Certainly, it's gratifying to hear how the residency curriculum has evolved since I graduated yesterday. I could ask lots of you questions. I want to ask Austin, your presentation about the HCC stuff resonated with me, and I wondered, I'm sitting next to Dr. Gochner here, and I'm looking at your data, I'm saying, wow, Austin generated $1 million in extra revenue for the clinic. That's phenomenal, like $1 million, and we're able to acquire an extra osteopathic table and an ultrasound probe. And of course, we know that $1 million in savings from the HCC coding theoretically comes somewhere to the system, right? Something that I've struggled with in my system where we work, and we have administrators and people trying to upcode our HCC and remind us on who, all of your patients this year that you haven't coded your HCC for yet, and these reminders that we get. I think what myself and a lot of my colleagues struggle with for years now is all this extra work that we might do during those visits, in addition to what else the patient is actually presenting with or what's on our agenda. Seeing that extra work go from my input of that work to actually something that reaches me in the clinic. So those actual $1 million, if they are real, how are those actually arriving in my clinic and helping me provide this care to patients? And I wonder if you experienced or your colleagues experienced fatigue with these sort of like prompting to do extra coding work. And how do we fix that? How do we make that more transparent, the connection between my coding work and the support I'm getting to improve the care for my patients?
Yeah, that's a great question, and I think that's something that we continually need to look at with it. For our clinic specifically, I mean, the residents are doing a lot of the HCCs, and then Castell is going through a lot of the patient charts, and they're prompting us to use those codes with a chronic condition review. As far as where do the physicians see the benefit in that, and where does that come? A lot of that goes on the back end, and I'm not necessarily privy to the data on where that actually comes through.
If I can add to that, luckily within our EMR, some of those HCCs should stay available within the chart so that the next residents coming through hopefully aren't starting from scratch. So speaking to your burnout issue, hopefully the EMRs can be used in such a way that it is made more readily available to the residents taking over the care as we transition out of residency and new people come in.
So Mark, did you have a question, or are you just trying to get attention standing up? Okay. I have one quick question for Bo, and then we'll turn the time over to our next three presenters. So Bo, this is a little bit hypothetical. As you look at going into your sports medicine training with an emphasis also on outdoor and wilderness medicine, how do you see the portable ultrasound potentially being useful in a backwoods environment?
Part of this fellowship will include manning some medical tents for an ultra marathon that's held at Lake Tahoe. So that is an example where thinking through my equipment bag of what I'm going to take, having a charged ultrasound probe would be very helpful. It's unlikely to be a piece of equipment that I would take with me on a long backpacking trip journey, simply for the weight and the questionableness of its utility. If I'm 3 days in on a 7-day trek into the wilderness. It would depend also on the individuals who are coming with me on their trip and their medical background. Having taken a few wilderness medicine courses now, that is a large factor that helps an individual influence what medicines and equipment they would bring, is that of the people joining them on their trip.
Yeah. Thank you. Okay. Next round, who's up?
Okay. Hear me okay? Yeah. Hey, I'm Kyle Christensen, and talking today about transportation at Porter Clinic. Nothing to disclose. So, thinking about Porter Clinic, where it's situated, and the conveniences that it offers to us and to patients, you know, it's not too far from the front entrance of the hospital, only one floor down. The front entrance isn't far from the bus stop. And then for us, close to the inpatient unit, close to our conference room, our workroom, the cafeteria, and just how, you know, if a patient comes in decompensated or even in an urgent or emergent situation, it's pretty easy to get them up to the emergency room or to directly admit to the hospital. As far as access to the clinic, that's kind of where my thoughts around this presentation went. So, by a raise of hands, who rode in a car to get to Weber State today? And did anyone use public transit, the new OGX? Super convenient, every 10 minutes. Has anyone ever used public transportation in Ogden before? So, few hands, but you know, it's definitely not the ideal way for people to get around. And just think about if public transit were your only option for getting to Weber State or, you know, nearby to McCady Hospital, how long would it take you? Harrisville, not that far away, 20 minutes by car. The fastest you could get here by bus is about an hour. Downtown from Midtown to McKay, 12 minutes by car, but almost 33 minutes by bus. So it brings up a problem, the fact that half of adults in the United States will be diagnosed with a chronic medical condition like hypertension, diabetes, cancer, and the fact that these conditions require frequent visits, especially right after diagnosis. And when patients can't get to their healthcare provider, how that affects, you know, changing medication and their treatment regimen overall, and how if they don't make their appointment, that change doesn't happen, and down the line leading to further complications, decompensation, et cetera. In the US, it's estimated that 3.6 million people simply don't get medical care at all because of transportation barriers. And these individuals are more likely to be older, poorer, less educated, female, or from an ethnic minority group. You know, Porter is no exception to people having issues with transportation, people using public transportation, and you know, Ogden, definitely not the most robust public transportation. In the United States, the Salt Lake doesn't even break the top 50 as far as cities for percent of population using public transportation. The top is New York, and like 56% of people that live there use public transit regularly. Number 50 on that list is New Orleans, and that number is only like 8% of people use public transit regularly. Salt Lake obviously lower, and then Ogden lower still. So to look at how people get to Porter Clinic, we posed a 3-question survey, whether that was they got here by private vehicle, public transit, or other. There were like someone walked and someone else got a ride with someone. I would consider that private vehicle. Do you have any problems accessing transportation, whether cost is a barrier, physical disability, or the stop for public transit just isn't in a convenient location for you? And then the real kicker, does transportation and access to it affect your ability to make or keep appointments at Porter Clinic? And the results showed that almost a quarter of patients over the 2 weeks that we surveyed everyone got to clinic that day by public transit. As far as transportation barriers, the colors are a little off or confusing, but cost here was the most commonly reported barrier for getting to clinic. That was about 12% of people. And of the people who said they used public transport to get there, they also said cost was an issue. 42% of people said that. Looking in a little more detail, did a logarithmic regression analysis comparing each of those listed barriers to the likelihood of also saying, yes, I have issues with transportation that affect my ability to make or keep appointments. And the two red circled were the statistically significant answers on that survey. So people who said that the cost of transportation is a barrier to their getting to clinic were 42% more likely to say that they have trouble making or keeping appointments. And then not having easy access to public transit, they were 81% more likely to also say that transportation is an issue with making or keeping appointments. and thus more likely to not get that medication change, the dose change, the monitoring of their A1C, et cetera. Taking public transit at all did have a small increase in the odds of having trouble keeping appointments, same with physical disability, but those ones weren't statistically significant. And so the next steps from this, as has been rumored for years, but apparently is really happening, the clinic is going to be moving to the location of the old McCady Hospital just across the street from where we are now in the office building. And there isn't a stop for public transport for the bus. And actually, the bus routes away from that area and through the Weber State campus before going back to Harrison Boulevard and up to the hospital. So it's even further if public transit was the thought. I have heard that there is likely going to be a bus stop on Harrison Boulevard for that when the clinic moves. That was information from the clinic manager, but haven't been able to verify that. It was mentioned that it would be on Harrison Boulevard, and that's a pretty big hill to go down from Harrison down to the medical office building. It took me at my resident in a hospital walk about 5 minutes to get down from there, and 5 minutes back up. And you can imagine if you are using a walker or in a wheelchair, wheeling yourself back up that hill. Plus, if the clinic is over there and you have, say, a time-sensitive lab or a diagnostic image that needs to be done, now they need to get up the hill, back on the bus, over to the hospital, into the lab, and if they don't have time, if transportation is an issue in the first place, it's hard to imagine the hospital taking on the liability of transporting patients from one location to the other, especially where maybe they have a physical disability and it's just a liability waiting to happen. Also, the clinic visit is what we were surveying, but that's only a part of the picture. If a patient gets a prescription, now they have to get to the pharmacy, and maybe the pharmacy is not easily accessible by transit, or they need to get to physical therapy, occupational therapy, and don't have an indication for home health to come out and do those therapies for them. And then thinking about how telehealth could be used to address some of these barriers for, and then a mail delivery pharmacy. I don't actually know if there's home health or telehealth for physical therapy, but I could see it. So some potential next steps. As far as limitations for this, obviously people who were surveyed were physically at the clinic, and if you have a transportation barrier in getting to clinic, it was probably underrepresenting the people who have transportation issues. In all the meta-analyses that I could find on the topic, no one could ever really put numbers on how much a difficulty with a transportation barrier, how does that affect your A1C numerically, what is the difference in blood pressure control, and keeping up with labs, et cetera. And how do you even intervene on these kinds of things? Insurance benefit to get someone to the clinic, especially in a capitated model, it's definitely going to be cheaper to pay for someone to go from their house or where they live to the clinic than it is to admit someone for a heart failure exacerbation even one time. So is it going to be worth it for the clinic to look into how do you get people from where they are to where you are? And a study linking the numbers to A1C control and blood pressure control and how much the cost of that affects, that it's so many layers involved that I think it's doable, but a lot more information is needed here. So I just want to thank Dr. Madsen, Celeste, the clinic manager, the MAs who administered the survey, and I believe it was Dr. Sharman that had the initial thought of what are we going to do when the clinic moves and we can't get patients in to be seen. So that's what I had. Thanks. TBD.
Okay, good morning, everyone. I just wanted to go ahead and introduce myself and my topic here. So my name is Preston Christensen, one of the third-year medical residents, obviously. And my topic is about ovulation induction with letrozole, specifically in patients with PCOS. So, and I have no financial disclosures or conflicts of interest. So next steps for me, looking forward to this August moving to back to Southeast Idaho, a little town called Soda Springs, Idaho. So for those of you who are not familiar, this is Alexander Reservoir right there in town, and that's going to be approximately my view from my office. So feel free to be jealous as much as you'd like to. Over here to the left is actually the world's only natural contained geyser. So we all know about Yellowstone, but this one is actually even more faithful. It goes off every hour on the hour. So if you're in town, stop by, have a look. And yes, there is actually carbonated water that comes up from the ground at multiple points in town. So anyway, kind of an interesting little city and looking forward to moving there. I'll be doing full scope family medicine also, primarily outpatient with OB, and then also some hospitalist and ER as well. So just a little bit of background about my topic and why I chose it. So for many decades now, clomiphene citrate, better known under the trade name of Clomid, has been the mainstay for ovulation induction in patients with PCOS. Obviously, we know that managing PCOS is multifactorial and depends a lot on the goals. In the case of pregnancy, though, Clomid is a lot of times synonymous with PCOS for a lot of people and has worked very well for many years. We know that there's many other adjunctive treatments, and we all know about the benefits of weight loss as well as metformin, and multiple other supplements have been researched over the years, each with varying degrees of success, also with their limitations. In more recent years, over the past decade or two, there's been rising interest in the off-label use of Femara or letrozole for ovulation induction and kind of taking the place of where clomiphene citrate has previously been used. So I just wanted to investigate that a little bit more. Quick note here, I am using the Rotterdam criteria of PCOS. This is the predominant diagnosis criteria, although there is some debate there. For those less familiar, it's basically two of the three of the following. Hyperandrogenism, either DHEAS or the testosterone, and then oligo ovulation or anovulation, which obviously makes pregnancy a lot harder if you're not actually producing eggs, and then ultrasonographic evidence of actual polycystic ovaries. So I just wanted to give that little bit of background so that it would make sense what we were talking about. So the mechanism of action for what has heretofore been used is one of the more elegant pathways in medicine, I think many would agree, is the HPO axis. So that's hypothalamus to the pituitary and then onto the ovaries. And of course, in the case of patients with PCOS, they have the hyperandrogen state and that results in a hyperestrogen state as well. The clomiphene citrate, it acts as both an agonist and an antagonist at the estrogen receptor. I think for the purposes of this presentation, it's better to think of it as an antagonist. So basically, you can see up here we have blockade at the level of the hypothalamus, blocking those estrogen receptors, and thereby resulting in an increase in the GnRH, an increase in the LH and FSH, getting that nice spike, and as a result, an ovulation. So it's worked very well for that. It does have some drawbacks, though, which is that unchecked blockade, in other words, that continuous blockade as long as the drug's in your system, can result in kind of runaway GnRH stimulation and LH stimulation, and therefore increased risk of multiple ovulation events and therefore twins or other multiples. Also, there's the anti-estrogen effects of the Clomid effect on other parts as well, such as the endometrium and the cervical mucus. Obviously, that's not desirable for pregnancy as well and presents a challenge. So this is where letrozole comes in, a slightly different mechanism of action. It is an aromatase inhibitor. So aromatase basically is the enzyme that results in the conversion of the androgens, which we know is high in patients with PCOS, into estrogens. So by blocking it down here, see if I can get that to work. By blocking it down here, we are able to, I guess, more indirectly block the production of estrogen. And as the effects of the letrozole fade quicker, we get that more natural, appropriate negative feedback, and therefore, theoretically, monofollicular development. So I know it's kind of a meaty explanation there, but I think it's kind of important to get that background and understand what the theoretical benefits of the letrozole is. So really the question I would like to answer is, should we be using should we be using letrozole instead of clomiphene citrate for ovulation induction and pregnancy in these patients with PCOS? So I know there's a few holdouts out there, so this talk is for you. And then, of course, is it safe and then efficacious? So I thought I would start out with the safety profile. Obviously, we don't want to do harm to our patients. First, do no harm. So looking at the safety, the rates of miscarriage between letrozole and Clomid, this is a Cochrane review done by Franek et al. He reviewed actually a total of 41 randomized controlled trials. This has been updated a couple times over the years, and really quite an impressive number of total women. And we can see that there is no difference in the rates of miscarriage between the letrozole and Clomid. It doesn't even rise to the level of statistical significance. Although quite rare, at least in this, with either of these medications and in this context, ovarian hyperstimulation syndrome is a theoretical possibility and quite rare with both medications. One of the earlier studies, just as interest in this was kind of kicking off, in 2006 with Togas et al. They looked at a total of 911 newborns. And overall, they broke it down into all different types of categories, both major and minor, and then by system, and found no statistical significance for either major or minor malformations. And if anything, found that there was a slight increase of congenital cardiac anomalies in the Clomid compared to the letrozole. You can see even though that's quite small. So how about multiples? I kind of alluded to this earlier, that letrozole has that theoretical advantage that it should decrease the chance of having multiple ovulation events, and therefore it should decrease the risk of multiple pregnancies. Usually not high order, although there is a case study of sextuplet being conceived with letrozole. That would be highly unusual. And we could see that also they found no difference between the two. If you look at it, the odds ratio actually seems to favor the letrozole a little bit more, but it doesn't quite rise to the level of statistical significance. So once again, this might be an area of further research, but nothing definitive. So now now hopefully I've convinced you that it's not something that you're going to cause significant harm to your patients on. I'd like to address the question of how effective is it actually. So one of the first big randomized control trials here with Legro et al. It was a double-blinded, multi-center randomized control trial with a total of 750 women evenly split down the middle, with Clomid on one half, letrozole on the other, and using the Rotterdam criteria. And they found that letrozole had actually more cumulative live births, which is of course the primary outcome here, in those who received letrozole compared to those who received Clomid, specifically comparing those two. And no significant difference in pregnancy loss, which was consistent with the previous data. So certainly seemed to be effective. Really, I think this Kaplan-Meier curve says it all, and I think this is kind of the take-home point. So if you look up here in the upper left, this is all patients together. We can see that letrozole is clearly superior to Clomid in terms of total live births. Now, I think it is interesting, and I'll talk about this a little bit more in a second, but there does seem to be a variable effect depending on the BMI of the mother or would-be mother. So if we see up here in our patients with lower BMI, overall, they do have a higher likelihood of responding to either of the medications. However, even there, the benefit with letrozole is notable and statistically significant. If we look here, though, at the BMI, the raised BMI, we see the difference is even larger. So in terms of absolute numbers, it is a little bit lower, but the difference is more noticeable. So the meta-analysis that I've referred to a couple times that was published in Cochrane by Franek showed that letrozole compared to the Clomid with or without adjuncts resulted in higher live birth rates. As you can see, the odds ratio there of 1.72. I thought this was kind of an impactful thing to consider, is that the number needed to treat for an additional beneficial outcome, in other words, comparing letrozole to Clomid, was 10. So to put it in other words, for every 10 patients that you prescribe letrozole rather than Clomid, you'll have one additional live birth with that. So how about adverse reactions? We know it's safe, but how tolerable is it? Just anecdotally, I know I've spoken to a lot of people who have taken both of these medications and say that they much prefer letrozole. However, the data does show a little bit more of a mixed picture. Hot flashes seem to predominate a little bit more in Clomid, whereas fatigue and dizziness seem to predominate a little bit more in the letrozole group. So how does ACOG feel about the matter, and have they opined on it? Yes, in their opinion number 738, they initially recommended it for women with PCOS and elevated BMI above 30, and it should be considered first line. They even went so far as to say. Since then, they've actually broadened it out and recommended it for women of all BMI, likely due to more reassurance about its safety. Has there been research into the different protocols? There has been. There's been proposed 5-day protocol versus a 10-day protocol. Ultimately, with all the research that I saw, it was underpowered to really recommend one over the other. That being said, the 5-day protocol seems to be the most common one. There's also been some debate or some different theoretical benefits over when to initiate in the cycle. Either days 3 to 7 or days 5 to 9 seem to be the competing protocols. And once again, it's underpowered to really, there's not really enough well-powered studies to recommend one over the other. That being said, the day 3 to 7 protocol seems to be the most common one. Administration doses, there is, once again, some debate whether we should be using the 2.5 milligrams or 7.5 milligrams daily from days 3 to 7. That being said, this seems to be what is generally done. So like I said, from days 3 to 7, typically you'll start at a dose of 2.5 milligrams, timed intercourse, and then test for ovulation by checking progesterone levels early to mid-luteal phase. Some variation there about when that's done. And then if there is no ovulation, increase the dose up to 5 milligrams. If there's still no ovulation, increase the dose. And once you've found the dose that effectively induces ovulation, then you maintain that for multiple months before potentially considering other options for pregnancy. Another important thing is checking for pregnancy prior to initiation of another round. So a few things I would just like to discuss and bring up here is that it's well known that PCOS is a rather heterogeneous illness, and there's probably multiple different phenotypes that are at play. We, just out of convenience, we use the Rotterdam criteria, which kind of lumps them all together. In reality, it's probably true that all of them benefit some, although it's reasonable to think that maybe some of these phenotypes would benefit more than others, just not very practical. We also probably need better powered studies to assess tolerability, as well as safety. That's one distinct advantage over Clomid, is that although hopefully I've convinced you that it's safe, Clomid has been around for 4 decades, so it's kind of hard to argue with that. Another thing is generalizability to other anovulatory or idiopathic diagnoses of infertility. Occasionally we see this, that where we really can't find a specific diagnosis, don't quite meet the right criteria for PCOS, and yet we try, a little bit of letrozole, a little bit of Clomid, and see what sticks. And then the cost is comparable and cheap, which is also, worth bringing up. So, what's my conclusion? It works. So, bringing this home a little bit. These are my 3 children. All 3 have actually were conceived with letrozole. As you can see, monofollicular development is not always a guarantee. So, a little bit rapid fire there. And then I'll save the questions for afterwards. Thank you.
All right. Hello, everybody. Nice to be with you. I'm Zach. We'll be taking a look at phentermine today, an old medication, but maybe looking at some newer data. After residency this summer, I'll be moving to Manti, Utah, joining the family clinic there in Manti, and I'll also be associated with San Pete Valley Hospital. I was once asked if this was the hospital. Unfortunately not. That would be really cool. We're very excited to be moving down there. I have no disclosures. So I think it's pretty well known by now that obesity is a growing health concern in the United States and really around the world. This is the CDC's map of the incidence of obesity in 2011. And if we compare that to the 2022 map, we can see that this has really been a challenging health concern to combat. And clearly we are still in need of better solutions for this. Obesity, it's a complex disease. There are lots of things that contribute to the development and maintenance of obesity as a disease, and it's been correlated with up to 200 other medical conditions, of which I've just listed a few of them here. And it's increasingly recognized as a chronic disease that is relapsing and progressive. Generally thought that 5 to 10% of weight loss is what is needed for a clinically significant benefit for our patients. This is kind of where my personal interest for this topic came from. Just in my training, I've heard such a broad range of statements about phentermine, from everywhere to, it's only approved for 3 months, you use it, you just gain the weight right back, why use it at all? To obesity is a chronic disease. It should be treated like a chronic disease, and I've had patients on phentermine for years, and they've had few side effects, and it's worked really well. So I thought, is there any evidence to back up either of these approaches? Here's just a brief overview of phentermine. It was first approved in 1959, so it's been around for a while. It is a sympathomimetic amine. It actually only differs from amphetamines by 1 methyl group. It works at the same receptors as amphetamine to increase norepinephrine and epinephrine in the brain, and that's how it produces the appetite suppression. Most common adverse effects are dry mouth, constipation, and paresthesias. The pros to this medication, I think the biggest one is probably that it's cost effective. There was actually a cost effect analysis that was performed in 2019 that included all the currently available anti-obesity medications. In that study, they did find that semaglutide was the most effective for weight loss, but they found that phentermine was the most cost effective, even more so than phentermine topiramate. Which makes it very appealing, I think, to us as physicians because it would be available to a broader range of our patients. Average weight loss for phentermine is also in the 4 to 12% range, which does hit that 5 to 10% to be clinically significant category. Some of the cons associated with phentermine, abuse potential is a concern for this. It is a stimulant medication and very similar to amphetamines as we see, which is scary, I get that. Cardiovascular disease is also a concern. I think the concern for this primarily stems from the fen-phen 1970s incident. Fenfluramine, was implicated to cause valvulopathies in patients. Phentermine never was implicated in that, and it remained on the market. And then often cited weight regain is thought of a con of this as well when the medication is stopped. Though I think it should be noted that this is also a complication of the GLP-1 medications that are coming out. We'll look at two studies today. This is the first one, looking at the long-term effectiveness of phentermine, as well as are there significant cardiovascular safety concerns with this medication? Uh-oh. That's okay. So this was just going over the design of the study. It was a retrospective cohort analysis. So they looked at 14,000 electronic health records of patients that had had a first-time phentermine fill in a specified time period of 3 years. Most of the patients were white, non-Hispanic, with a BMI on average of 37. They divided the patients into kind of 3 different groups. They had a short-term group, which was essentially 3 months, a medium-term group that was anywhere from 3 months to a year, and a long-term group that was from a year and beyond. Most of those patients had been on long-term phentermine for up to 8 years. So this is the data that they showed. This is percent change from the baseline body weight. You can see that for the short-term groups, they never really hit clinically significant weight loss for any of the time periods analyzed. So I think for my preceptors that thought phentermine wasn't effective, if you only used it for 3 months, you were probably right. It's really not effective, right? They gained everything back at the 2-year mark. But maybe my other preceptors were right as well, who said, yeah, if you use it long-term, it probably is effective for maintaining long-term weight loss of a clinically significant amount. This is a sub-analysis they did of that data, so they called this the responder-only analysis, where they only looked at patients who in the first 3 months had lost 3% or more of their body weight, and then looked at the long-term data for those patients. And you can see for each group at every time point, the effective weight loss was more than in the previous data set. They also looked at effects on heart rate and blood pressure. There were no significant changes in heart rate for any of the groups at 24 months. There were some small changes in the intermediate time intervals at 6 and 12 months, but they were very small. I think 3 to 4 beats per minute was all that they noticed. They did look at the difference in blood pressure as well. These are the systolic blood pressure data. So for the short-term group, there was a slight increase. For the long and medium-term groups, there was a slight decrease, though these did not reach statistics significance. And as you know, by taking blood pressures in clinic, this could change from minute to minute. They also looked at the incident of cardiovascular disease or death. So they included MI, stroke, any coronary artery disease interventions, and death in that analysis. And they looked at this from the time of the first phentermine fill out to 3 years of phentermine use. Of those almost 14,000 patients they looked at, there were 41 patients that had one of these events reported, which was about 0.3%. So pretty low incidence. It would have been nice to see a matched population to their study to see what kind of the natural incidence of these events in that population would have been, but they didn't have that data available. They also did a hazard ratio analysis. They found that there was no difference in the hazard ratios between any of these groups. They actually had to combine, the medium and long-term continuous groups because there were no events at all reported in the long-term continuous group. So So some promising data, but there are some limitations. Selection bias certainly could have been a possibility, as patients that did not have adverse effects from phentermine or were having good success with the phentermine were more likely to take the medication for a longer period of time. It is kind of hard to generalize these results. It was a very homogeneous population, a low-risk population. There was a small number in the long-term group. There was only about 52 patients in that group, where the other groups had 300 to 500 patients each. It would have been nice to see factors that could have affected these results as well, including lifestyle changes, but they didn't have that. So on to study number 2. This one's looking more at, is there risk for phentermine addiction? Specifically, were there any evidence of psychological dependence, craving, abuse, or withdrawal symptoms? This was a clinical intervention trial that was performed at a private fee-for-service weight loss clinic. They recruited patients that they had had on phentermine from 1.1 clear up to 21 and a half years, 8 years on average. And you can see the doses for the phentermine in that category range quite a bit. The FDA approval for the highest dose is about 35.7. Some of these patients were well exceeding that. In the short-term group, these were patients that were new to their clinic, had just started taking phentermine at different doses as well. Part of their reason for picking these two groups is one of their underlying assumptions was that if phentermine is addictive, it would have a more prolonged mechanism than, say, amphetamines, because you don't have that fast high and drop. It would be more similar to something like hydrocodone, where it takes multiple exposures to that medication over a period of time to develop dependence on it. They essentially said, what happens if we stop phentermine abruptly in these patients? To evaluate this, they used these 4 different psychometric scales. The severity of dependence scale is a screening tool that's often used in cocaine and amphetamine users to screen for substance use disorder. For the mini international neuropsychiatric interview, they specifically focused on module K of that, which is a structured DSM-4 interview to diagnose non-alcoholic substance use disorder. They came up with what they called the phentermine craving questionnaire, which was a modified cocaine craving questionnaire, and then also the phentermine withdrawal questionnaire, which was a modified amphetamine withdrawal questionnaire. So first, looking at the severity of dependence scale, scores on this can range from 0 to 15. A score of 3 is generally thought of as a positive screen. You can see that the scores for both the short-term group and the long-term group were quite low, and there was no statistical significance between the groups. In fact, if you look at this is the long-term group data over here, and there were only 2 patients that scored above a 3, indicating a positive screen. Kind of for comparison, cocaine and amphetamine users on this scale have an average score of about 4.2. For the diagnostic interview for DSM-4, they interviewed all of the long-term patients, and they did not, based on that structured interview, give any diagnoses of substance use disorder in those patients. The authors did comment that each of these patients were well known at the clinic, and that they thought these results were in line with what they observed in clinic, which was very few drug-seeking behaviors for any of their patients. For the phentermine craving questionnaire, this one looks at 4 different factors of craving for a total score. The statistically significant ones were lack of self-efficacy, which you can actually see the long-term group actually had a lower score than the acute group, as well as for compulsivity. Again, the long-term group score was lower than the acute-term group, and the total scores were significant as well. Again, lower in the long-term group, which is the opposite of what you would expect for somebody who was addicted to that medication. For the phentermine withdrawal questionnaire, this one looked at a bunch of different things. Well, I should explain, sorry. So day 0, this is a baseline day where the patients did take phentermine on that day. Day 1 is 24 hours later, and day 2 is 48 hours later, where they did not take phentermine on those days. There was a significant difference in their withdrawal scores between each of these days. Scores were highest on day 1. The really only significant sub-item that was different on the days was their hyperphagia score. So patients felt more hungry on days that they didn't take it. They actually did an analysis where they admitted the hyperphagia item, and there was no significant difference between days when they did that. So that brings up the question, is feeling hungry a symptom of withdrawal or a loss of a therapeutic effect? And kind of for comparison, patients taking amphetamines generally score in the range of 13 to 17 on this withdrawal questionnaire. So much lower scores here. Again, some limitations. Again, possibility for selection bias if they were having success and few side effects. I thought there was also a possibility for some strong interviewer bias in this study, given that the patients were very well known to the investigators, specifically thinking of the diagnostic interview. Again, it's difficult to generalize this, and while it was a clinical intervention study, they did not have any randomization, placebo control, and it was not blinded at all. So where do we need to go in the future to see if this would be a beneficial and effective treatment for obesity? We need more data and higher quality data. This is one study that's currently ongoing. It is a randomized controlled trial. It's double-blind, placebo-controlled. They're hoping to get about 1,000 patients for 2 years of treatment with phentermine at 8 milligrams TID, and they're looking at a bunch of different outcomes. Preliminary results are expected by 2027, so not too far down the road. Maybe we'll have some more data about phentermine. Here's my resources, and thank you.
So questions for our last 3 presenters, and if you've thought of questions that you should have asked before, those will be allowed also.
Question on the phentermine. So I've always been a 3-month guy for phentermine. And I think I still understand the FDA does still recommend 3 months and then off. Is that correct?
That is correct.
Yeah. So in theory, that was interesting ideas, and I mean, obviously they need more studies, but I was really most surprised about the graphic where you showed that the effectiveness increases with time. I would just think the opposite. What I found in my own anecdotal world is that the biggest effect is the first month, and then you start to lose effect after that.
Having urinary tract infection symptoms. Yeah. She's requesting a UA or.
And I've always kind of figured the reason was a tolerance effect, that once you pass the first month, you get a little bit of tolerance and the effectiveness of the medicine starts to go down. But what you suggest is just the opposite. So now I'm kind of rethinking my whole thoughts about phentermine. Any help for me on that one?
Yeah, that's a good question. Certainly with stimulants, you can build up the tolerance. I've in my short tenure as a physician, I've had just a little bit of experience with prescribing phentermine, and I've had patients on it for 3 months, 6 months. I have one patient who's been on it for about 9 months. I just think anecdotally, her experience has been similar to what was shown here in these studies. Interestingly enough, so she did have some pretty significant weight loss in the first 3 months, but then after that, she continued to have kind of this slowly progressive weight loss, which was interesting to see. Some of the comments that she's made to me is that when she's taking the phentermine, she just feels like she doesn't think about food as much as she used to. She doesn't worry about it in addition to not being as hungry, and she's felt like that's helped her make much healthier food decisions as well. And so I guess I don't have a perfect answer for you. I'm excited for maybe some new data, but at least anecdotally, my experience has been similar to that study. And granted that one patient is very low risk, kind of the same population as in the studies.
All right. Awesome presentations, guys, all of you. Thank you for that. I have a question for Zach and one for Preston. Zach, I've used Phentermine quite a bit as well, and I feel like it actually works pretty good. One thing, though, I've noticed is some people it works well for, the responders, and then some people it doesn't work very well for. Is there any studies that show how to parse those patients out before starting, or just kind of trial and error with that?
I'm not aware of anything to parse that out, just trial and error.
Okay.
Yep.
And then Preston, I felt a personal attack about no, I think that was a great study about letrozole. I think that it looks like it is an effective medication compared to clomiphene. The concern that I think people has had in the past with clomiphene, with letrozole was the cost, but that looks like it's a little bit less nowadays. As remarkably, clomiphene is, despite being a generic, it's getting more expensive. But the safety, I guess, is kind of the other big concern. It does look like, as far as miscarriages and birth defects, it's about the same. But the kind of the more concerning side effects, especially with being a aromatase inhibitor, like the vasomotor symptoms and things like the cardiovascular and the bone mineral side effects, I guess, are somewhat more concerning. Has there been any studies showing the safety profile of that medication with those?
Yeah, I mean, with regards to the other effects, I guess I didn't see anything. I didn't see that was studied. It's worth pointing out, though, that in both cases, Clomid as well as letrozole, is usually used for a short period of time. I mean, only 5 days. I don't know if that rises to the level of, enough to have a actual physiologic effect or not.
Just a couple of questions. Preston, I want to dovetail on that. What is the regimen that's used for Femra? Again, I'm a late adopter. I wouldn't know about this except you guys in the clinic, and I'm learning from you.
Yeah, so, and maybe I kind of rushed through that part a little bit, but there's a few different regimens out there. Most typically, this is you'll either wait for natural menstrual period, and that starts day 1, or you can induce it by withdrawal from OCPs, as you're probably familiar with. And then, so that starts the timer. And then starting on day 3, you'll start with 2.5 milligrams, typically, regardless in all patients. This is typically what's done daily. You don't need any monitoring. You don't need to monitor the ovaries or anything. 3, 4, 5, 6, 7, and then stop. And then after that, that's when there should be the spike in LH, FSH, result in ovulation, timed intercourse, and then hopefully pregnancy after that.
Okay.
However, it's also important, as I also briefly mentioned, that you should be checking progesterone level to at least to get the right dose to ensure that there has been an appropriate rise. Once you see that rise, that's basically, not a guarantee, but it's highly predictive of.
So you're checking that level on what day do you?
I mean, I've seen different days. I don't know if there's like a really consensus. Actually, and not to dominate time, I don't know if you had questions for the others, but interesting anecdotally, not to make things too personal here or anything, but in our case, we used letrozole for the first round, checked progesterone, it was very low, implying that the dose is not appropriate, and then waited, there was still no period or anything, and before we knew it, she was pregnant. And so even though she had theoretically not responded, I think we probably, thinking back about it, I think we probably checked the progesterone too early. So I think, if anything, I would err for mid-luteal phase, if not a little bit later in the luteal phase, just to make sure that you're not,
Sure.
sampling it too early pre-ovulation.
Okay, great. Hey, quick question for Zach, and that kind of similar. The last study you said that's ongoing, the LEAP, it talked about Phentermine 8 milligrams TID. That's foreign to me. Can you talk about dosing and what is done in clinical practice?
That is definitely not typical dosing. I've never seen that dosing before or seen any evidence for that dosing. In clinical practice, your dosing options are kind of 8 milligrams, the 15 milligram dose, and then the 37.5 milligram dose, which most people end up on the 15 or 37.5 once a day. Yep, usually in the morning. Insomnia is another common side effect of Phentermine, and so that would be one of my worries with the TID dosing, is that you may worsen the insomnia side effect dosing. Interestingly enough, if patients are having side effects on the 37.5 milligram dosing, there hasn't been shown to be much difference in the amount of weight loss between the 15 milligram and the 37.5 milligram dosing. So you may not need much higher than the 15.
Kyle, so has there been talk about a shuttle system for patients between Porter Clinic and the hospital to mitigate the problem of getting patients back and forth and so forth?
Not that I know of. In the discussion with people involved, it was like the conversation went basically that would be, I guess, risky to do, but probably not that hard, just because the staff shuttle from the parking structure is pretty close to where it would need to pick people up from the clinic. So, yeah, but as far as actually planning on what they might do, I'm not aware of. So.
Preston, so the letrozole, you focused on PCOS. I mean, are you talking about infertility generally or just in that population?
So yeah, I mean, what I had discussed was specifically in PCOS. I mean, we know that a large amount of infertility is, either multifactorial or idiopathic. I suppose those are kind of different things, but I think a lot of that has to depend on the situation. I mean, so where I do my practice in Midtown, a lot of the times the possibility of sending them to a reproductive endocrinologist is very limited for a lot of our patients. So I think in our case, even if we don't suspect PCOS as the cause of infertility, I think it's still worth consideration. That being said, I mean, I think that's, even then you open up the floodgates even more because there's such a wide variety of reasons for which someone could be infertile. I still think that's probably worth doing an initial workup in cases of infertility, as much as is feasible. So typically that would be like a hysterosalpingogram, potentially ultrasound. Although even those two, I think you could probably forego, and then at the very least a laboratory workup, looking for anti-mullerian hormone, and then baseline hormone levels.
For the transportation study here, you said you had a questionnaire, but there was no information about the questionnaire. Number of people questioned, seasons, different days of the week, etc. Could you answer that?
Yeah, we did it, had it as part of the face sheet when a patient was checked in to the clinic over a course of 2 weeks, and that was in early March, I believe. So I did think about how weather is definitely involved in people who use public transit probably over people who use private vehicle. So and ended up surveying about 56 people, I think.
So before we close and go off to our lunchtime, I want to point out that these lectures were actually sponsored by Steve, Joyce, and Val Johnson in memory of Vernal Johnson. So Vernal Johnson was a longtime caregiver in our community and was skiing on his 100th birthday at Snow Basin. So thank you for the Johnson family in supporting us and our residency. One other final comment, like Mark Johnson, I thought that our phentermine use was highly restricted. And that's an eye-opening bit of information. So thank you, and thank you all. It's been a pleasure to have the opportunity to work with you, and thank you for your presentation.